Hi, and welcome to our presentation on celiac disease. I'm Pippi Idle, and my group members are Sasha Fernandez, Jordan Harrison, Caitlin Kelso, and Emma Scholand. We're excited to share some information about this disease, and hopefully you all find this as interesting as we did. Let's get started. So here is our case study. Michael is 20 years old and is an avid mountain biker and climber, born and raised in Sedona. He began experiencing GI sensitivity in late November, and by March, he had lost over 15 pounds. His girlfriend talked him into visiting his primary care physician after he bailed on a weekend bike trip with his friends because he was too tired. On his physical exam, his physician notices that he has a red, patchy rash on the back of his neck. She asks how long it's been there for, and he reports it has been on and off for several years. Michael was adopted from Thailand, and he knows he's lactose intolerant, but he grew up running track and has never thought of wheat as a problematic food. His PCP orders a blood test, which is positive for IgA, anti-tissue transglutaminase antibodies, and shows evidence of anemia. Michael is advised to follow a strictly gluten-free diet, and by June, he's feeling much better. His rash is gone, and he is beginning to regain his weight. His PCP diagnoses him with celiac disease. Now, some background and history about celiac disease, which is also known as celiac disease or gluten sensitivity enteropathy, which is disease of the intestine. This disease is characterized by an abnormal autoimmune response to the presence of gluten, a protein found in wheat, barley, and rye. But what exactly is gluten really? So it can be described as the storage protein of wheat grains, and it's not actually just one protein, but several. The FDA labels gluten as any product that will trigger celiac disease. And in 2007, an optional label was included to describe gluten as an ingredient that is any species of the grains wheat, rye, barley, or a crossbred hybrid of these grains. And 20 ppm of gluten, which just means that there are 20 parts gluten particles for every 1 million particles of other ingredients, is defined as the legal limit for optional gluten-free labeling. And now Caitlin will be telling you guys about the symptoms and presentations for celiac disease.
Thanks, Pippi. Symptoms of celiac disease are body-wide and manifest in a variety of ways, with more than half of adults also having symptoms unrelated to the digestive system. Digestive signs include diarrhea, fatigue, weight loss, bloating and gas, abdominal pain, nausea and vomiting, and constipation. Because this disease affects the body's ability to absorb vitamins and minerals, it can impact the level of iron in the blood, often leading to iron deficiency and, in some cases, anemia. Celiac disease may also lead to a loss of bone density, also known as osteoporosis, or softening of bones, also known as osteomalacia, and can cause joint pain. An itchy, blistery skin rash called dermatitis herpetiformis can form on the body as well. The brain is not immune to the reach of CD, and symptoms such as headaches and fatigue may present as well as nervous system injury that can cause a numbness and tingling feeling in the hands and feet, possible problems with balance, and cognitive impairment. Interestingly, presentation of symptoms of celiac disease may be different in children and include failure to thrive in infants, damage to tooth enamel, weight loss, anemia, irritability, short stature, delayed puberty, and neurological symptoms. These symptoms can be attributed to the body's inability to sufficiently absorb nutrients from the small intestine. So, celiac disease occurs in about 0.5 to 1% of all populations worldwide. As you can see, in Finland, the incidence is about 2.5%. In the United States, it is about 0.71%. In Italy, it is 0.57%, and in Sweden, it is 0.53%. Risk factors for celiac disease include genetics, family history, sex, and medical conditions. Research suggests that specific genes are associated with autoimmune diseases, and having them increases the risk of celiac disease. For celiac disease, certain variants of human leukocyte antigens DQA1 and DQB1 have been identified as increasing a patient's risk of developing CD. Individuals with a family member who has celiac disease and/or dermatitis herpetiformis may be more at risk. Women are 2 to 3 times more likely to be diagnosed with celiac disease than men. Additionally, other medical conditions such as type 1 diabetes, Down syndrome, and autoimmune thyroid disease can increase the risk of celiac disease. Sasha will be going over pathophysiology.
Thanks, Caitlin. Reaction to gluten in celiac patients is an autoimmune process, not the histamine release that we usually refer to as an allergy. Here's how the body's reaction to gliadin, one of the proteins that make up what we call gluten, works in people with celiac. First, gluten is broken down into gliadins and other peptides. The gliadin fragments interact with chemokine receptor 3, causing the release of zonulin, which is a protein that triggers increased intestinal permeability. Due to this increased permeability, gliadin is able to reach the lamina propria, which is the tissue that lies deep to the epithelium of the small intestine and surrounds the gastric glands. When the gliadin reaches this tissue, it triggers the release of interleukins 5 and 8, as well as keratinocyte growth factor. This results in the recruitment of neutrophils into the lamina propria. Additionally, toll-like receptors, which are there to detect foreign particles, cause upregulation of maturation of immune cells and release pro-inflammatory cytokines, which induce apoptosis of intestinal cells, leading to release of intracellular tissue transglutaminase. This causes gliadin, the original protein, to be deamidated, which means that an amide group is removed. And this triggers activation and maturation of B cells when presented to helper T cells. This also produces several types of antibodies, IgM, IgG, and IgA, which will be searching for tissue transglutaminase. T helper cells also produce interferon gamma and TNF alpha, which increase gut permeability and initiate enteropathy. Here we can see a model of the pathway I described. At point 1, gliadin fragments are interacting with chemokine receptor 3, causing the release of zonulin. This zonulin, as I mentioned, will interact with a membrane protein, which is what you can see at point 3, and that will increase the permeability of the membrane. This allows gliadin to travel into the lamina propria, triggering the release of the interleukins as well as the keratinocyte growth factor and recruiting intraepithelial lymphocytes. At point 12, you can see the toll-like receptor is causing the release of pro-inflammatory cytokines and the maturation of immune cells. Eventually, the intestinal cells will undergo apoptosis, releasing tissue transglutaminase, and that will trigger the deamidation of gliadin. Then, as I mentioned, the gliadin deamidated will trigger the activation of B cells as depicted at point 10. And finally, IgM, IgA, and IgG antibodies are produced against tissue transglutaminase. Emma will be telling you all about the diagnosis of celiac disease and some potential therapies.
Thanks, Sasha. Diagnosis for celiac disease usually includes blood tests, endoscopy or biopsy of the duodenum, and a 4 out of 5 standard of care. Serological blood tests are based on EMA, which is anti-endomysial antibody, anti-TTG or tissue transglutaminase, and DGP, deamidated gliadin, antibody or protein, and may also screen for signs of inflammation and malnutrition in the blood that would occur from tissue damage and impaired nutrient absorption. An endoscopy of the duodenum would check for mucosal changes and flattened villi that indicate celiac disease. However, this procedure might not be necessary for pediatric patients who already present high serological results, which would be over 10 times the normal value. The gold standard for diagnosing celiac disease is a combination of a positive serological test result and a duodenal biopsy. However, the current standard of care for diagnoses is based on a 4 out of 5 rule, meaning that if the patient presents at least 4 of the following symptoms, they likely have celiac disease. These symptoms include the typical signs of diarrhea and malabsorption, antibody positivity, HLA-DQ2 and or HLA-DQ8 positivity, intestinal damage, and clinical response to a gluten-free diet, meaning that the patient's symptoms improve after removing gluten from their diet. As of right now, the only treatment for celiac disease is eating a completely gluten-free diet. This includes being cautious of cross-contaminated surfaces. However, there is good news for those who are unable to follow such a diet, as drug therapies are currently being tested, with 2 in phase 2B of their clinical trial. These drug therapies are a zonulin antagonist, which would block zonulin from increasing intestinal permeability, and a gluten detoxification, which would include bacteria-derived peptidases capable of breaking down gluten. The zonulin inhibitor AT1001 specifically has been tested to show greater tolerability and reduction of gluten-induced intestinal barrier dysfunction. Other possible drug targets include inhibiting zonulin activity to improve compromised gut permeability, targeting undigested peptides, inducing gluten sensitization, targeting the adaptive immune response, the innate immune response, toll-like receptors, microRNA, dysbiosis, and genetic susceptibility. Jordan will be covering prognosis and some interesting things we found.
Thanks, Emma. The long-term outlook for people with celiac disease can vary because some people have no symptoms, while others have severe malabsorption features. Overall, people with untreated or unresponsive celiac disease have increased early mortality compared to the general population. Without diagnosis and treatment, celiac disease is ultimately fatal in 10 to 30% of people. Currently, this outcome is rare, as most people do well if they avoid gluten. And then here is some interesting information we found. Numbers of diagnoses appear to be increasing, and that is not just due to increased awareness of CD, but actually increased incidence. Possible implications are thought to be the hygiene hypothesis, which theorizes that the improved hygiene and lack of exposure to various microorganisms have been linked with a steep increase in autoimmune disorders in industrialized countries in the last 40 years. Celiac disease acts as a unique model of autoimmunity, and it's beginning to show a shift in its own paradigm. This suggests that the autoimmune process can be arrested between the environment and genes in reestablishing the intestinal barrier function early on. Intestinal permeability tends to precede disease, which leads to autoimmune response. Early correction of intestinal barrier defects is an innovative therapy that can treat many autoimmune diseases and not just celiac disease. Additionally, there is no consensus about whether oats are safe for those with CD, as they are not closely related to wheat, but produce similar proteins. Oats themselves do not have any gluten, but they are often harvested and processed with the wheat and therefore have the potential to be contaminated with gluten. And lastly, onset of CD can occur at any age, but there are two peaks of onset shortly after weaning with gluten before age 2 and the second or third decades of life. And then here are our sources, and I hope you guys enjoy this presentation.